I had a patient, relatively young patient, just with hypertension, and very famous Italian climber, who came in the hospital in 2012 with a non-staining, and at the radial approach the LAD had some irregularities, and the right coronary artery was occluded at its distal part and some stenosis at the mid part of the right coronary artery. There was placed a bare metal stent, Titan and POBA on the distal part, and the patient was sent home. He performed a scintigraphy. It was completely asymptomatic at this point, and scintigraphy demonstrates ST depression in these leads and ischemia in the inferolateral part of the heart. So he came back to the hospital, asymptomatic patient, and the right coronary artery was occluded. The colleague tried to reopen it without success, and he decided to go on and perform FFR on the LAD, and you see here the distal collaterals for the right coronary artery. FFR was 0.75, and there was placed a test in the mid-LAD with FFR 0.79, borderline FFR, but the procedure was stopped here. For 2 years, the patient was completely asymptomatic. He continued He continued to do his daily activity, climbing on the mountains, opening new paths in the mountain. And on May 2014, he performed again the scintigraphy, and you see the depression here in these leads, and again the same ischemia in the inferolateral wall. So he was referred to the coronary angiography, asymptomatic patient with known right coronary artery occlusion, and I performed the right coronary artery to the radial approach. You see no changes, so I can consider it as a chronic total occlusion of the right coronary artery. His left artery was these some irregularities, good result from the stent in the mid part of the LAD and collaterals, and maybe some ostial LAD irregularities here. So I remember that one of the legends was said, if you don't want to do angioplasty, do FFR. Obviously, it's not like that, but anyway. So I performed FFR to the LAD, and the LAD was 0.70 FFR. This is the FFR in the LAD with the 6-French catheter to the radial approach. So what to do now? We had a patient completely asymptomatic with the inferolateral ischemia, occluded right coronary artery, collaterals with the right coronary artery, ostial LAD stenosis stopped full and positive LAD FFR. So I decided to try to reopen the right coronary artery, to repeat again the FFR on the LAD, and if it's normal, finish and stop here, otherwise to treat somehow the ostial lesion of the LAD. So, okay, here is the passing the catheter, the wire through the occlusion over the wire balloon and the contrast. I'm going a little bit quickly on the technical part. Here the two wires in the both branches, and here, here is the pre-dilatations of the lesion with different balloons and kissing technique. And at this point, I had a result like this before placing of the stent. So I decided, well, why not to put an AXXESS stent in this bifurcation, even if it was a chronic total occlusion. Anyway, the result is good, so maybe I can put an AXXESS stent. An AXXESS stent passes through 7 French catheter if you have 2 wires, but I was with the 6 French. The idea to go again to measure the LAD, so the shiftless catheter was not a good idea. 7 French catheter to the radial approach maybe is not. I don't like to use 7 French catheter to the radial approach. So here you can see the removing of the wire and down the second wire. Here you see the AXXESS stent, how it enters in the right coronary artery. On the next images you can see positioning of the stent. Obviously, as the stent is a little bit bulky device, the contents doesn't pass very good, but anyway you can see here is before, after the bifurcation. Here is maybe at the exact place of the bifurcation. We start slowly to open it here and separating the markers. On these images you can see here that the 3 markers are very good separated, so they engage the bifurcation. And here you can see the final definitive opening of the AXXESS while push it to engage good the bifurcation. And I think here we can see or appreciate the final result of the stent and the bifurcation. So at this point, we go back to our strategy and we change the catheter. We put the guiding catheter to the LAD. You see here the access stent on the right coronary artery and no collaterals on the, from the left coronary artery to the right coronary artery. And here you can see the FFR, which is completely normal FFR. At this point, the patient was discharged. I prepared for him a scintigraphy after 3 months. It was done on December after the case was accepted. I little bit anticipated the scintigraphy to this patient, and you can see here the completely normal SAT movement during the exam and no ischemia in this patient. So, well, we had this patient occluded artery, FFR positive LAD, right coronary artery, FFR positive here, scintigraphy positive, and with the reopening of the right coronary artery, with the access stent on 6 French catheter, normal FFR, normal scintigraphy. So the conclusion is well, the most important conclusion is that we need some patient-oriented evaluation with an appropriate patient, because maybe this patient, maybe, I'm not saying maybe, for sure, I think it doesn't need even to perform the third angiography, but anyway, once done, careful interpretation with all results, FFR in any dark lesion in this ostial LAD asymptomatic patient, just it's good to perform FFR, it's obligatory to perform FFR and to interpret this FFR with the global anatomy, coronary anatomy, and at the end, the technical part of the conclusion that access, which is a self-expandable bifurcation stent, could be done very easy, even with a 6 French catheter, with one wire, in total occlusions, in myocardial infarction, I have some cases. So that's everything of my presentation. I'm leaving here. That's why I like to talk about bifurcations. Thank you very much for your attention.
Thank you very much. But I think one important point that this case demonstrated that FFR is very dependent on the extent of the territory. I mean, because the LAD is supplying the occluded RCA, then you get a positive FFR. When you restore the normal anatomy, the lesion is not critical anymore because the territory gets smaller. I think it's a very elegant demonstration of something that is well known. It's nice to see clinically.
But it's a dramatic demonstration. To see the FFR go from 0.75 to 1, to me is, I was surprised. That's a dramatic demonstration.
I tell you that an 80% lesion as a number means nothing. If the territory is very small, 80% is non-critical. That's the reason why some 90% focused stenosis in a diagonal branch have a normal FFR, because the territory is very small.
Yeah, and it also shows that if you treat the LAD, you're not going to normalize the FFR with that kind of large territory that's still not revascularized. So you think the lesion in the LAD was ostial? So it looked to me like it was a diffuse segment in the LAD proximal. Did you do a pullback when you did the FFR initially?
This is, I performed FFR for the distal part, because there was a stent on the mid part of the LAD.
Right.
And it was critical even in the distal part. So the problem was the ostial, so I put the FFR on the proximal part of the LAD to exclude the mid part of the LAD and to have the big territory, measuring FFR on the big territory in this patient. That's why the FFR pullback. I'm not using pullback because I'm not using the infusion of the adenosine. Different places to measure.
That's a fascinating.
It's also an interesting application of the AXXESS stent. So distally, with one wire and opening up the side bench, very nicely demonstrated. I have to say, you know, the stent looks funky, but you can see how far down you can get with the stent. Very successfully with a very, very impressive result.
We have some patients with one wire just because starting with 6 French and you decided not to change, so you have to remove the second wire.
Yeah, and I mean, you see the markers were we're covering the carina very nicely, so you wouldn't need anything else to do. Very well done. Thank you very much.
Thank you. Thank you very much.